Hi, everyone, and welcome to the fifth Redtalks event. My name is Emmanuel Gomez. I'm the R&D director at Kalimkano Institute. As you know, we aim to support the lymphoma community on state-of-the-art collaborative research and development for the final benefit of patients. So here we are, and we will discuss with today's speaker about CAR T. The webinar platform allows you to all discuss in the chat tab on the right of your screen and ask questions on the dedicated tab. The question will be then asked to the speaker by the moderator. Speaking of whom, today I have the honor to assist and introduce the main moderator, Professor Guillaume Cartron. He is an hematologist, head of the clinical hematology department at Montpellier Teaching Hospital, a member of the research team Hematopoiesis and Immunotherapy at Molecular Genetics Institute of Montpellier. He is the president of the scientific committee of the Patient Association France Lymphome Espoir, member of the LISA board, and president of Kalim Steering Committee. Thank you, Guillaume.
Thank you, Emmanuel, and good afternoon, everybody. And thank you very much for your participation to this Red Talk 5 organized by our Institute Kalim. So today, CAR T-cell are now used daily in our center. They have dramatically transformed the management of patients with lymphoma and probably will soon be indicated in other hematology malignancies such as myeloma. Beyond these results, by agreeing to genetically modify our own cells for therapeutic purpose, our society has opened up new horizons in many disciplines. This is why, beyond this medical revolution, CAR T-cells are definitely the precursor of cell and gene therapy treatment, which will revolutionize entire areas of medicine and particularly oncology and infectious disease. We are fortunate hematologists who contribute significantly to this medical revolution. For all these reasons, the Carnot Lymphoma Institute, Kalim, has already initiated the implementation of resources, particularly in the fields of imaging and biology, in order to quickly initiate ambitious translational research programs. In this context, we are particularly pleased to welcome Dr. Jordan Gauthier, who is an assistant professor at the Fred Hutchinson Cancer Research Center at the University of Washington in Seattle. He was the first physician to be awarded the Fred Hutch Immunotherapy Integrated Research Center Fellow Award. He is also an expert in the field of CAR T-cell therapy and hematopoietic stem cell transplantation. And Dr. Gauthier has made significant contributions to the CAR T-cell therapy field. Especially, he was the first to characterize the factor associated with outcome after repeat infusion of CD19 CAR T-cell in patients with relapsed or refractory B-cell malignancy. In addition, he's investigated an innovative combinatory approach using ibrutinib concurrently with CD19 CAR T-cell in patients with refractory CLL, and his research is also focusing on predicting and preventing severe toxicity after CAR T-cell therapy, such as cytokine release syndrome and neurologic toxicity. Today, Dr. Gauthier will present this main result as well as the question that remain unresolved to this day. And Jordan, I suggest that you can split your presentation in 3 parts, which will allow us to ask him questions and make his presentation more interactive. To all of you, thank you for passing on your question that we can ask to Dr. Gauthier. Jordan, the floor is yours. Thank you for your participation to this Red Talk 5.
Thank you, Professor Cartron, and all of the Kalim team for the kind invitation. Very excited to be here today and to talk about CAR T-cells. And as Professor Cartron mentioned, I will be focusing on 3 main themes today. So first, my disclosure and some disclaimer that I will be discussing the use of primarily one CAR T-cell product that is not approved by the FDA. And this is something to bear in mind. So overview, 3 main things, 3 main parts. We're going to try to make this as interactive as possible throughout the use of technology. So feel free to post your questions in the chat. First part, I'll be talking about the use of ibrutinib with CD19 CAR T-cells for CLL. Next, we'll be talking about the role of lymphodepletion intensity and even more importantly, the cytokine response to lymphodepletion and progression-free survival in patients with aggressive lymphoma who are treated with CD19 CAR T-cells. And lastly, we'll be talking about repeat CAR T-cell infusions. Is the approach feasible? Does it work? What are the factors associated with the success of these repeat infusions. So let's get started with the use of ibrutinib with CAR T-cells. As we know, BTK inhibitors and other targeted agents have really transformed the management of CLL over the past 5 years or so. But in patients with high-risk cytogenetics, in particular patients with complex karyotypes, in most patients, the duration of response will remain limited. And if we look at 2 or 3 years, the progression-free survival in these patients is going to be quite low in the 25% range. So there's clearly room for improvement, and the need to find some potentially curative approaches in these high-risk patients. And if we look at data at the bottom of the slide here, in patients who discontinue ibrutinib, either for disease progression or because they do not tolerate the treatment, there's extremely poor survival, and this is obviously not in the frontline setting, and this is prior to the venetoclax era. But at this time, looking at this retrospective data from the MD Anderson Cancer Center, the median overall survival was 20 months. So clearly room for improvement in to treat these high-risk CLL patients. And looking at the current landscape of CAR T-cell therapy targeting CD19 for refractory CLL, it's still, even though we've got data now that was first published back in 2015 from the Penn group, it's still relatively early days for CAR T-cell for CLL. And overall, across different studies, relatively small number of patients, but some quite encouraging results in terms of overall response rates, complete response rates, on encouraging results regarding the depth of these responses as well. So as you could see, I've highlighted 2 studies here, and I'll be talking about what lessons we've learned from our early results that we published first in JCO in 2017, and I'll be diving a little deeper into how to improve these results using concurrent ibrutinib, and this is experience and data that we've reported recently in Blood as well. So first, I'd like to spend a few seconds to really describe the data and the clinical trial that generated this data. So this is a phase 1 study that was carried out at our institution at the Hutch of the use of defined composition CAR T-cells, and that's really quite specific to your platform. This is at the top of the slide, the schema of the lentiviral vector. As you could see, this is shared with many other CD19 CAR T products using the FMC63-derived scFv. We're using an IgG4 hinge, a 4-1BB co-stimulatory domain, and also a truncated EGFR, which allows us to track the CAR T cells by flow cytometry. So very specific to the platform, as I just mentioned, is the defined composition approach. And in the middle of the slide is shown a summary of the manufacturing process, which starts with the CD8 and CD4 subset selections, that is followed by transduction, in vivo expansion of the T cells, of the CAR T cells, and finally, eventually, formulation of a CD8 to CD4 1-to-1 ratio CAR T cell product. This was a phase 1/2 study, and we investigated 3 dose levels from 2 × 10⁵ up to 2 × 10⁷ CAR T cell that was administered after lymphodepletion chemotherapy. So the primary objective of the study was safety and feasibility. And here, specifically for CLL patients, these patients had to be beyond first remission, had been exposed to chemoimmunotherapy, as detailed here on the bottom right of the slide. And in patients for whom ibrutinib became indicated as first-line therapy, they had to be refractory to ibrutinib, that was defined as progression or absence of response to ibrutinib. And the lessons from these large phase 1/2 trials that eventually we ended up treating 195 patients on this trial across 3 disease types. We established that cyclophosphamide and fludarabine lymphodepletion was the optimal regimen, leading to robust in vivo CAR T-cell expansion and persistence and higher response rates, as well as prolonged duration of response. We established 2 × 10⁶ CAR T-cells as the recommended stage 2 dose, and in particular in the CAR-naive setting. And we'll see at the end of this presentation that things may not be as simple in the CAR-exposed setting. And lastly, importantly, we identified a strong association between the tumor burden, could be the marrow burden, the nodal disease, and in vivo CAR T-cell expansion. So we can easily model these different outcomes as a function of in vivo CAR T-cell expansion, and we kind of facing a bit of a double-edged sword situation where more robust in vivo expansion is both associated with a higher likelihood of response, and here in blue is depicted the MRD negative marrow response by flow cytometry in CLL patients. But unfortunately, this is also associated with an increased risk of significant toxicities in gray, cytokine release syndrome, and in red, severe neurologic or grade 2 above neurologic toxicity. So we do have this conundrum or trade-off that we have to deal with. So to further improve the outcomes of CD19 CAR T-cells in CLL patients, we thought that the administration of ibrutinib concurrently with CAR T-cells could potentially be beneficial. And initially, on our first reports on the phase 1/2 study, ibrutinib was in all patients discontinued at some point prior to lymphodepletion and prior to leukapheresis. And some of these patients had been off ibrutinib for a long period of time, and some stopped ibrutinib shortly prior to leukapheresis. And there's a very strong rationale that continuing patients on ibrutinib might be beneficial. Firstly, we know that when we stop ibrutinib in some patients, we can observe a rapid nodal progression that we call a tumor flare, and that could be detrimental to the efficacy of CAR T-cell therapy. We also know that ibrutinib modifies or alters expression of some chemokine receptor and can mobilize CLL cells into the bloodstream, into the bone marrow from the lymph nodes. There's also a large body of data suggesting that we can improve T-cell fitness and CAR T-cell function by combining it with ibrutinib. There's also data in mouse models showing that ibrutinib was associated with a robust in vivo expansion, but lower rates of cytokine release syndrome. So based on this, we carried out this pilot study, and I will refer to these two different groups of patients. There was the no ibrutinib cohort. All of these patients had stopped ibrutinib at some point prior to leukapheresis or lymphodepletion. And the second group, the concurrent ibrutinib cohort, that was scheduled to be on ibrutinib for at least 2 weeks prior to leukapheresis and to continue all the way through for at least 3 months after the infusion of CAR T cells. Briefly, the patient and disease characteristics. This was in these 19 patients. This was a very high-risk population. Most patients had high-risk cytogenetics, 17p deletion or complex karyotype. Median number of prior therapy was 5. And at the time, 60% had received venetoclax prior to study entry. Overall, the approach was well tolerated, and about 70% of patients could continue on ibrutinib as planned without discontinuation. We did have to reduce the dose of discontinued ibrutinib in a handful of patients, and we did observe one event of a presumed cardiac arrhythmia that led to a sudden death in one patient that was experiencing grade 2 CRS in this cohort. In terms of the efficacy, high response rates combining ibrutinib with CAR T-cell, and this is early on, 4 weeks after the infusion, 83% of overall response rate, and deep responses in 72% of patients by flow cytometry and 61% by IGH sequencing. And again, this is something that we've shown as well in lymphoma. We see that the depth of response is associated with the duration of response, and we could see that CR patients do better compared to PR patients, compared to stable disease patients. And this is true looking at the IWCLL stratification and also looking at depth of response by IGH sequencing. And in terms of the feasibility and the tolerability of the approach, we actually, interestingly, we observed lower severity of cytokine release syndrome with a median grade of 1 compared to 2 in the no ibrutinib cohort, and comparable rates of neurologic toxicity. We could see actually numerically lower rates of any grade neurologic toxicity compared to no ibrutinib, but this did not reach statistical significance. So interestingly, because we know that in vivo expansion is associated with toxicity and tumor burden, we were kind of curious to find out what could explain these results. And we were expecting to see lower tumor burden with ibrutinib, and that's what we see: lower LDH serum concentration, lower nodal burden as well, lower percentage of marrow CLL cells in patients with concurrent ibrutinib. And in addition to seeing lower severity of toxicity, we were expecting to see lower or lower numbers of CAR T cells in vivo, but this is not actually what we saw. We saw actually comparable, if not higher, in vivo expansion of CAR T cells, particularly for CD4 CAR T cells. You could see on the left side, this is the longitudinal data that is smooth with a non-parametric smoother. You can see in red patients with receiving concurrent ibrutinib with higher numbers of CD4 CAR T cells. On the right side, you can see box plots showing you the peak value, the peak in vivo expansion of CAR T cells. So very intriguingly, despite having lower tumor burden and developing less toxicity, we see very robust, if not comparable or even superior in vivo expansion of CAR T cells. And when we compare head-to-head with the limitation of small numbers between the concurrent and the no ibrutinib cohort, we saw a numeric trend towards higher response rates by IWCLL criteria, 83% compared to 56% without ibrutinib. So very encouraging findings with this. This is a retrospective analysis, obviously, of two sequentially treated cohorts. And we've demonstrated that this approach is overall feasible, very efficacious with high rates of MRD negative responses, and very intriguingly associated with lower CVRS severity. And particularly the fact that despite lower tumor burden, we've seen equivalent and even higher in vivo expansion of CD4 CAR T cells. And I didn't have time to show this data, but that was also associated with lower serum concentrations of key cytokines that we know are correlated with severe cytokine release syndrome, suggesting that ibrutinib may modify the cytokine milieu and be beneficial to prevent toxicity. We did observe one case of a fatal cardiac arrhythmia in a patient who had developed mild grade 2 CRS, and this was actually also reported by the Penn group at ASH in 2018. So we now have implemented as a standard practice guideline to closely monitor these patients who are on a BTK inhibitor, and particularly on ibrutinib, who do develop cytokine release syndrome after CAR T-cell therapy. I think that's almost the end of the first session. A quick summary of the current landscape for CLL. This is still early days, but promising results in terms of the rates of response and the durability of response, although I would say that further follow-up is needed. And ibrutinib, the role of ibrutinib, and we have data from small pilot studies suggest a beneficial effect, that it may improve efficacy and maybe even improve the toxicity profile. But having said that, looking across the different studies, CRS and particularly neurologic toxicity still remains an issue, with rates of severe neurologic toxicity ranging from 5 to 29%. So there's clearly something to improve in that area. There is to date no FDA or EMA approved CAR T-cell product for CLL, and we anticipate in the future, particularly based on the results from the Transcend CLL 004 data and studies using CTL119, that we may see approval in a reasonable time frame. We are currently investigating an approach using another BTK inhibitor, currently at the Hutch, acalabrutinib, in combination with commercial axi-cell, and we have this study actually open and enrolling. That just started. I think this is it for the first part, and I'd be happy to chat a little bit more about this.
Thank you, Jordan. We have actually a lot of questions. Maybe just the first one very quickly. You have mentioned acalabrutinib as a perspective, but you have mentioned that mechanism of action of ibrutinib in this context is quite heterogeneous with a lot of off-target activities. So how do you see things with acalabrutinib in this context?
I agree that because in some way ibrutinib is a dirtier drug with a lot of off-target effects, it might be actually the biological rationale, particularly on the ITK inhibition and in potentially restoring T-cell fitness, is more attractive compared to more targeted BTK-only agents. So I agree that ibrutinib in that way is probably is a very interesting drug because it has a lot of off-target effects for sure.
A lot of questions actually in the question tab, and I'm sure you will have to stay a little bit longer, Jordan, offline then to answer all. Maybe I will start with the first one. Were non-CAR T cells activated in a bystander fashion?
Sorry, can you repeat that?
The question from Cedric Miller in the
yes.
question by the fact that non-CAR T cells were activated in a bystander fashion.
Yeah, probably activated in a bystander fashion, and so endogenous non-transduced and just endogenous T cells. They are likely activated in the tumor microenvironment, and we're working at the moment on tissue data and sort of sorting out or passing out what could be the effect of these non-engineered endogenous T cells, but we don't have the answers right now. But they are likely activated, and there's likely contribution of endogenous T cells.
A question about T cell harvesting in these patients with ibrutinib CART. How do you collect those T cells, and do you stop ibrutinib before apheresis or not?
So what we classically do is we hold a dose of ibrutinib 24 to 48 hours prior to the LUCA, and it's mainly for the hemorrhage, for the bleeding risk. So we usually hold 1 or 2 doses prior to the cell collection, but it's a really short time frame, because the whole point is to have patients being exposed to the drug as when we collect the T cells. But we do hold a dose or 2 prior to collection.
Okay, and maybe a last one, and then we will have to discuss at the end of the talk. But did you evaluate the tumor burden by PET scan for MTB?
We did have PET-CT data in many patients, with the challenge that some patients have low FDG avid disease and some others have higher FDG avidities, which makes the data. But the response rates by using Lugano PET-based, which is not included in the IWCLL criteria, were also quite good. And I think off the top of my head, in the 70% range as well. So we do see good efficacy even in patients with high FDG avid disease. And to answer specifically, we did not look at the metabolic volume, the TMV, in this study specifically.
Okay, thank you, Jordan. I think it's 23. We will go to your second part of your talk. Thank you.
All right, great to see a lot of questions. Okay, now I will change gear a little bit, and we're going to talk about aggressive lymphoma patients that receive CD19 CAR T-cell therapy, and how can we predict duration of response in these patients. And apologies for the horrible green shades here. This looks like there's a bit of a filter on the slides. Anyway, across these different, we know that CD19 CAR T-cells in aggressive lymphomas, this is recapitulating the data across the pivotal trials that led to the approval of axi-cel and tisagenlecleucel in this indication. And I've added our experience with JCAR14 at the Fred Hutch, and overall high rates of overall response and complete response as well. And when we looked at duration of response, also a very encouraging and promising results with durable responses at 1 year in 60 to 80% of patients across these different CAR T-cell products. Again, always a little tricky to analyze across different products with heterogeneous patient populations, but this is the data that we have so far. And while this is very encouraging, there is still a significant fraction of patients that do not respond initially or will experience relapse after CAR T-cell therapy. And overall, the factors associated with response in PFS are not very well characterized. So using the similar data set that I've described to you before on this phase 1/2 study of defined composition CD19 targeted CAR T cells, we used a method called the ElasticNet, which is a shrinkage or regularization approach that allows us to screen a very large number of predictors because we know that these are very complex data sets, and a lot of factors can impact outcomes, patient-related characteristics, disease-related characteristics, such as the tumor burden, the tumor kinetics. We looked at a number of serum cytokines as well, serum biomarkers. We looked at the in vivo CAR T-cell kinetics and persistence, and some other variables related to the CAR T-cell manufacturing, to try to really find what were the critical factors independently associated with progression-free survival in these aggressive lymphoma patients. And we found that quite robustly we could identify 3 main factors that were associated with progression-free survival: the LDH serum concentration prior to lymphodepletion, the day 0 MCP1 serum concentration, and the peak IL-7 serum concentration. So higher LDH was associated with poorer outcomes, and conversely, higher levels of cytokines were associated with better outcomes. So interestingly, when we model this, we can sort of visually appreciate the effect of these cytokines. And while we adjust for the tumor burden and kinetics using the LDH, we can see that a higher tumor burden can be somewhat offset by this higher concentration of serum cytokines. So here, this is the 2 contour plots showing you the relative hazard for progression or deaths after CAR T-cell therapy. And you could see that a patient, even those with high tumor burden, in whom we measure higher concentration of cytokines, had a significantly lower risk of progression after CAR T-cell therapy. And this is really using an approach that does not assume any particular cutoff or threshold, and we can model nonlinear effects using an approach called restricted cubic splines, which is very nicely appreciated visually on using these contour plots. And to go a little deeper, we thought what could be causing or impact these favorable cytokine profiles, and we know that lymphodepletion is critical in that setting. And when we looked at MCP1 IL-7, we could find that patients who had received a higher intensity lymphodepletion that was defined as a dose of 60 milligram per kilo of cyclophosphamide had a higher MCP1 delta, a higher day 0 MCP1, and a higher peak IL-7 concentration compared to patients who had received a lower intensity lymphodepletion. And when we do a scatter plot looking at the MCP1 and the peak IL-7, so we look at patients who achieved both high concentrations of these 2 cytokines, we could find that it's almost exclusively seen in patients who receive higher intensity lymphodepletion. And we can quite easily categorize these patients with the intensity of lymphodepletion and if they had achieved or not a favorable cytokine profile. And we could see here that virtually the plateau that we're seeing was almost only seen in patients who had both received higher intensity lymphodepletion in addition to this favorable cytokine profile. So very interesting findings, and we try to link that to the in vivo CAR T-cell expansions that we know to be so essential and critical to the efficacy of CAR T-cell therapy. And what we found is that indeed in patients receiving higher intensity lymphodepletion, we observed higher initial peak in vivo expansion and higher persistence of CAR T-cells. Again, this is a little bit difficult to see here, but the borderline is showing you in red patients who received a higher intensity. In patients who had a higher MCP1 concentration at day 0, similar findings were observed with higher initial peak expansion of CAR T-cells and prolonged persistence of CAR T-cells in vivo as well. The right side is showing you when we look at the day 28 CAR T-cell transgene level in the blood and we model the risk of relapse after CAR T-cell therapy, you could see almost a linear relationships with a higher in vivo transgene level being associated with more durable responses. So in summary, what we've seen is that we think that lymphodepletion matters, but even beyond lymphodepletion, the cytokine response to lymphodepletion seems to be critical to maintain responses in CAR T-cell patients. We've seen that the peak IL-7 and day 0 MCP1 were independently associated with the PFS, even after adjusting for tumor burden or tumor kinetics. And interestingly, we've seen that this higher level of cytokines were almost exclusively seen in patients who had received higher intensity Cy/Flu lymphodepletion. In addition to that, we've seen and reported very recently at ASH, and we will talk about this as well at the upcoming ASTCT meeting, that IL-15 serum concentrations are also associated with superior outcomes, not so in NHL patients, but particularly in CLL and ALL patients. And this is seen as early as the pre-lymphodepletion time point. And so we do think that improving the cytokine milieu could be beneficial to induce more durable responses in these patients. There's different approaches that we are considering, which is the use of higher intensity lymphodepletion regimens, or to supplement patients with cytokines either before or throughout CAR T-cell therapy. We have previously reported some preclinical work using the compound NKTR255, which is pegylated IL-15, which showed very promising results in mouse models, and a clinical trial is underway. So that's it for the part. I'm happy to answer any questions right now.
Thank you, Jordan. So we have some question about this part of your talk from Cedric in Rennes. Which CLL2 receptor were expressed by your CAR T-cells?
We don't know. I don't think we've addressed the CCL2. I don't think we've looked specifically for that cytokines for that chemokine ligand. So I don't know.
And could you be more precise about your cytokine that you evaluate and were not significative?
How many cytokines? So we evaluated about 25 cytokines, and we evaluated IL-2, I can go through every single IL-5, IL-6, IL-15, MCP1, soluble IL-2 receptor alpha, different TNF receptor, soluble TNF receptor, interferon gamma, TGF beta, and a few others. And I'm happy to refer you to the paper. You can get the comprehensive list of cytokines that we assessed.
We have a question for bioclinician Catherine in Saint-Louis. They ask you about toxicity of the lymphodepletion in the context of CAR T, where we observe neutropenia probably more prolonged and more deeper than what we could expect with fludarabine cyclophosphamide, as usual, for example, in CLL. So how do you manage this neutropenia? Do you recommend to use G-CSF? And what is for you the mechanism of action? Because probably it is not the same and not only the direct effect on marrow and marrow suppression. What is your opinion about that?
Very interesting question. I think we could talk about this for an hour. We actually have we've shown before, I mean, in abstract form, and we have a paper under review. We looked at a whole data set, so about 190 patients, and looking at factors associated with hematopoietic recovery. So it's a very interesting question. I think there's differences across products, and our experience, I think, that is shared by others, is that potentially axi-cell is associated with more significant prolonged cytopenia, in particular neutropenia. But having said that, this very recent report for HSU and Dr. Magyar has shown that even after Kymriah, we do also see some prolonged cytopenia. We have seen some cytopenia prolonged as well, but it's actually it seems to be at a lower incidence, probably in the 10-15% range, so not as high as we've seen with other products, and it's not entirely clear why, but that's what we've seen. To answer the question, we have not seen that higher intensity lymphodepletion was associated with more prolonged neutropenia. We do see that it's associated with deeper initial neutropenia, but not necessarily a delay in the recovery of this of the counts of them. So we haven't seen that. Again, it might be true, and maybe we didn't have the power to detect that difference. We do recommend G-CSF use, and we've used it. I know that people were a little shy to use G-CSF based on the initial Eliana and Kymriah data in ALL patients, with concern that it may worsen cytokine release syndrome. In our experience, we have not seen this association. I think there's one case where you may want not to use G-CSF is in patients with very severe capillary leak syndrome. In that case, I would probably try not to use it. But in most patients, I think the risk of infections is, and we have seen some very severe infections in CAR T-cell patients during this period of neutropenia. So we lean on the side of preventing infections, and we do administer GCSF even in the early post-CAR T period to try to answer what the optimal day. I don't think there's one optimal day, but in our experience, we're comfortable using it early on after CAR T-cell, even when there is mild CRS or CRS being associated.
Okay, and another interesting question from Bertrand. You demonstrate that you observe the L7 peak, which correlate to PFS, but how you identify which cells contribute to L7 production in this case?
Yes, we have not. We are doing this analysis right now, and again, we know that IL-7 is produced by stromal cells in the thymus, in the bone marrow, preferentially, and other cell types as well. And we would love to know where is this IL-7 coming from. Can we really pinpoint the cell of origin? And we hope doing single cell assays will answer this question, looking at both the marrow, looking at some tissues as well, tissue samples, but we have not that answer yet, but that's a good one.
Okay, thank you, Jordan. Thank you, everybody, for the question. I suggest, Jordan, that you move on to the third part of your talk. Thank you.
Will do. Okay. So third and last part of this talk, I'll be talking about the feasibility and efficacy of administering a repeat CD19 CAR T-cell infusion. Even though CD19 CAR T-cell are all the rage, there are still a lot of work ahead, and complete responses are not seen in all patients, and some patients still relapse after treatment. And this is on the right side of the slide, showing you our data in large B-cell lymphoma, in aggressive lymphoma patients, and in patients with ALL, that even in patients with complete response, we do see some relapses in a significant proportion of patients. One possible approach would be to give these patients a repeat dose of CAR T cells, but there is quite limited data to date as to is it feasible to manufacture a new CAR T cell product? How toxic is it, and is it efficacious? So again, using the same data set from patients treated on phase 1/2 study that I've described earlier, patients were eligible to receive a repeat CAR T-cell infusion based on these three criteria: having persistent or relapsed CD19 positive disease after the first CAR T-cell infusion that they will refer to as CART1, having not developed any dose-limiting toxicities after CART1, and being at least 3 weeks after CART1. So looking at these 44 patients, there were some distinguishing features because we are looking here at 3 disease types, ALL, CLL, and NHL, and you could see that the majority of ALL patients had received a lower dose of 2 × 10⁵ CAR T cells. In contrast, most CLL and NHL patients had received what was considered the maximum tolerated dose of 2 × 10⁶. So that's a key distinguishing feature. At the time of the second infusion, all ALL patients received 2 × 10⁶ CAR T cells, and in contrast, about 70% of the CLL and NHL patients went on to receive a higher CAR T cell dose of 2 × 10⁷. And overall, almost all patients, about 90% of patients, received an increased dose at the time of the second infusion. And in terms of how to make a second CAR T-cell product using our in-house manufacturing, in 95% of patients, we could use cryopreserved material, either simply cryopreserved T cells or transduced T cells prior to the LCL stimulation in 52% of patients, or using manufacturing cryopreserved CAR T cells in 19 patients. Only 2 patients had to undergo a repeat leukapheresis and a de novo manufacturing from scratch. In terms of the in terms of the safety profile, overall, we did see some cytokine release syndrome, but it was mild and self-limited in virtually most patients. We did see grade 3 and 4 CRS in 9% of patients, and grade 3 and 4 neurologic toxicity in 11% of patients. So a very favorable toxicity profile. There was no grade 5 CAR T-cell related adverse events. In terms of the efficacy, overall, lower rates of response compared to what we know can be achieved in the CAR-naive setting, with only 3 responses in ALL patients, so 21%. A third of CLL patients responded with CRs in 2 patients, 20%. And in NHL, some more favorable results with 52% of overall response rates and CR in 20% of patients. Even though overall lower response rates, we did see some quite spectacular responses in patients with bulky disease. And this is just to visually show you an NHL patients with bulky abdominal nodal disease that had a very, very good response 28 days after CAR T-cell after the second infusion, and a CLL patients with bulky right cervical lymphadenopathies also enjoying a dramatic reduction. In terms of duration of response, with limited numbers in ALL patients, only 1 patient was still in response after receiving a consolidated allogeneic transplant, some durable responses in a handful of CLL patients, and a median progression-free survival of approximately 6 months in NHL patients. So the next step for us was to try to identify when is it worth it, what is associated with better outcomes after these second infusions. So we used an approach called Bayesian model averaging, again, to try to take into account all the numerous different predictors that could influence outcomes. That could be patient or disease related, some CAR T-cells related variables, lymphodepletion, the prior response to CAR-T1, the disease burden, the patterns of CAR T-cell dose augmentation, the timing from the first to the second infusion, the type of manufacturing. As you can imagine, many of these factors can impact. And what we saw is that quite robustly, 3 factors were consistently associated with outcomes, either response or progression-free survival after the second infusion. So what we saw is that Cy/Flu lymphodepletion prior to the first infusion was strongly associated with better outcomes. An increase in the CAR T-cell dose was similarly associated with better outcomes, and the type of disease as well, with better outcomes being seen in CLL and NHL patients. And when we sort of backtrack and categorize these patients, and these according to the lymphodepletion type prior to the first infusion and the patterns of dose augmentation in CLL and NHL patients, we could see that we could confirm significantly better anti-tumor effects in patients who had received Cy/Flu prior to CAR-T1 and an increased CAR T-cell dose with overall response rates of 70%. And this was really the only durable responses we observed were in that group depicted in red on the right side of the slide here, who received Cy/Flu prior to CAR-T1 and an increased CAR T-cell dose. So what could be responsible for better outcomes in this group? And we've shown time and time again, and this was again the case here, that in vivo CAR T-cell kinetics strongly associated with the efficacy. And this was also again something we confirmed here after a second infusion. Initial peak expansion and persistence were associated with response. So to try to better understand, we used multivariable linear regression to try to find the factors that were independently associated with more robust in vivo expansion. So interestingly, we confirmed again that having received Cy/Flu lymphodepletion prior to the first infusion was associated with more robust in vivo CAR T-cell expansion. But interestingly, the CAR T-cell dose augmentation was undetermined using this type of modeling. In addition, the CD19 burden and the type of disease was also impacting in vivo CAR T-cell kinetics. And when we categorized patients again with these 3 different groups, and we looked at the data longitudinally, and this is in bold lines using again the non-parametric smoother approximating the data, we could see that in patients not exposed to Cy/Flu prior to CAR-T1, Cy/Flu lymphodepletion, it had virtually no initial in vivo expansion and no persistence. In patients who did receive Cy/Flu lymphodepletion but received the same dose of CAR T-cells, they had good initial in vivo expansion but extremely limited persistence. And in contrast, patients who received both a Cy/Flu lymphodepletion prior to CAR-T1, in addition to an increase in the dose of CAR T-cells, enjoyed high initial in vivo expansion as well as more prolonged in vivo CAR T-cell expansion. And there's many things that could explain that, but one possible explanation would be the triggering of the priming of anti-CAR immune responses after the first or after the second CAR T-cell infusion. This is data that we've reported previously, that we could identify anti-CAR CD8 response that are directed at peptides or amino acid sequences that are located in the murine scAV. And when we looked at in a subgroup of patients with available data, we did find that this anti-CAR immune response were detected at in a higher proportion of patients in those not receiving Cy/Flu prior to CAR-T1, which sheds light into some of the possible mechanisms. In conclusion, we've shown using our approach, our in-house manufacturing, making a second CAR T-cell product was feasible. Overall, the toxicity profile was acceptable. We did see some durable responses in a subset of CLL and NHL patients. And importantly, we have identified 2 pre-treatment actionable factors: the type of lymphodepletion and the CAR T-cell dose as being associated with robust in vivo CAR T-cell kinetics and superior anti-tumor efficacy. The mechanisms explaining the overall lower efficacy of this repeat infusion of CAR T-cells is not fully elucidated. Immunogenicity is one hypothesis, obviously poor T-cell fitness or other factors that could be tumor-related or related to an immunosuppressive tumor microenvironment could also be impacting outcomes. We are and others are investigating strategies to improve outcomes of repeat infusions. We have one clinical trial currently open and enrolling, allowing the treatment of patients previously exposed to a murine scAV-bearing CAR T, and this is using a novel CAR T-cell product using a fully human scAV called JCAR21. Okay, I think I've reached the end. We've talked about these 3 main topics, and before we end, I would like to thank a lot of people I was very fortunate to work with, and the Hutch has, of course, a very rich history of using adoptive T-cell therapy. I would like to acknowledge the incredible mentorship from my colleague, Cameron Turtle, also David Maloney, who's the medical director of our immunotherapy clinic at the SCCA, all the wonderful and critical preclinical work that is done in Stan Riddell's lab. And I would like to highlight collaborations with Dr. Bezzera and Dr. Hirayama on these different projects, and all the wonderful people working at the Hutch, the SCCA, and the University of Washington, and finally also Juno Therapeutics for funding these trials. And thank you very much for the invitation. I know we may not be able to answer all the questions, so if you have, feel free to email me or ping me on Twitter, and I'd be happy to try to answer whatever question you may have. Thank you so much.
Thank you, Jordan. Thank you very much. We have some question about this third part. An interesting question from Sylvain about the source of the CAR T1 and CAR T2, and so the response. So did you compare response among patients that received CAR T1 and CAR T2 from a single production versus those that received CAR T2 from from a second production? Do you observe any difference between these 2 groups?
So only 2 patients had a second production, unless we did categorize patients according to different patterns, and you can see it was quite heterogeneous. We could compare from patients who had, if we could, it depends how you define your categories, but you could say that using N-manufacturing cryopreserved CAR T-cells versus using, we could say, pre-manufacturing cryopreserved T-cells, and we did not find big differences across these different groups. And only 2 patients had a full brand new de novo manufacturing of CAR T-cells, so we could not really compare with that group. But across either using pre-manufacturing T-cells or using N-manufacturing CAR T-cells, we did not see significant differences.
Okay, and did you check your prognostic factor for PFS that you described previously in this setting of CAR2 infusion?
So IL-7-MCP1, so we did some additional analysis that I think are hidden in the supplementary, and we did find some slightly different patterns, and I'd have to look again, but I don't think we found a strong signal there. But I think we focus mainly on some pre-treatment achievable targetable factors, and we did some exploratory analysis that were not part of the multivariable modeling, but just comparing across groups, and I expect we would likely see similar findings in terms of, because again everything related to strong in vivo CAR T-cell expansion is usually associated with good outcomes, but we haven't looked at it specifically.
And did you check before the second infusion the CD19 expression or not? I don't remember.
Yes, it was patients were needed to have persistent CD19 expression on the tumor, and it could be for CLL and ALL. It's usually easier, but yes.
And regarding your response rate and the other opportunity with B-specific antibody, what is your opinion between these two kind of treatment, B-specific and another infusion of CAR T? What is your opinion?
Well, I think at this stage, it's really sort of investigational and exploratory. I don't think we would want to go ahead and do that outside of a clinical trial. And anyway, we wouldn't be able to do it outside of a clinical trial. I think there's some interesting results and efficacy results using bispecific. So that's the approach we've been using. We've been also using at our institution as part of a clinical trial. So it's hard to have a really clear-cut opinion. I think it's too early to tell. But I think the key message from here is that what was considered the ideal dose of CAR T-cells in the CAR-naive setting may not be the optimal dose in the CAR-exposed setting. And I think it challenges a little bit the way we design these trials and the way in the future, because we're going to have the pool of patients that progressed after CAR T-cell is going to be larger, and we're going to have new investigational products that we will have to test. So we really need to take that into account, that our prior data in the CAR-naive setting may not translate to the CAR-exposed setting in terms of dose escalation and dose determining designs. So that's sort of my take on this.
Okay, thank you. Thank you very much, Jordan. Emmanuel, I suggest that you could conclude this very interesting Redtalks 5 organized by Kalim Institute.
Thank you, Guillaume. Thank you, Jordan, for being with us today. Thank you all for attending this Redtalks session. So please do not hesitate to suggest us issues you want to be discussed during those Redtalks. We will stay up to 30 minutes online to talk in the chat tab if you want. And if, Jordan, you're available, please do not hesitate to see on the questions tab. You have some question for you. Have a nice evening. Have a nice day for our US colleagues. And see you at the next Redtalks session teased by this short video. Bye, everyone.
Bye-bye. Thank you.
Thank you. Thank you very much, everybody. Bye-bye.